Hey, everybody. Cassidy, founder and creator of the Caregivers Hub, coming to you today. It is officially October 1st, and it is our monthly Caregivers Hub Hangout. And we do these Hangouts every single month. The first Sunday at 5 p.m. Pacific of every single month, we do these, unless, I get busy or there's a holiday or, sometimes just doesn't happen. But most of the time it does. And today I am super excited to cover this topic. We are going to get into the nuts and bolts of social work.
Yay!
Social workers. And on that note, I'm so excited to welcome my dear friend, my coworker, and just all around awesome person, Sharon Kroll.
Hello.
Yay. She's a clinical social worker in our hospice where we work together. And so we have a lot of questions that some of you threw out that we're going to answer more towards the end, but we're going to be talking about the role of clinical social workers and how social workers truly are a benefit to you. And we're going to kind of cover some other things in between then and now. But I want Sharon to come out and tell you a little bit about herself and her career as a social worker. So Sharon.
Oh, thank you. Well, hi, everybody. I'm very happy to be here. I've never done a Google Hangout before, so thank you for bearing with me while I figure out how to make it look good and speak to you clearly. So yeah, I've been a social worker for a super long time. I've been a social worker since 1986, before you were even born, Miss Cassidy, like way before, right?
No, 1 year after, actually.
All right. So I've done all sorts of parts of social work, ranging from working in outpatient community mental health clinics as a therapist. I have worked for school districts for a really long time. I was a school social worker when I lived out in New York for 2 different districts. That was about 19 years, believe it or not. I know. And also doing part-time working in other people's private practices. I've worked with sex offenders. I've worked with the victims of offenders. I moved out to Washington and I started working at Joint Base Lewis McChord, working in a prevention program for young Army families, which was amazing. And then I started working my way up towards the Seattle area. I worked for a year in home health. And then I decided that I wanted to check out hospice. And I heard such great things about the healthcare system where Cassidy and I work that I was so excited. It'll be about 4.5 years that I've been with the hospice that Cassidy works at. And we met in a really interesting way. Is it okay if I share that?
Absolutely.
All right. So I was at I work outpatient, not in an inpatient setting, like lots of states only have inpatient hospice, where people go to, either get immediate help or live out the rest of their days. But we have a different kind of hospice as well, which is outpatient. So we visit people in their homes. And so I was already in an adult family home and taking care of a lady and talking to the caregivers. And then I hear a nick knock on the door, and Cassidy came in and saw a really fun bumper sticker on my car, and we realized we both like the same music, and that's kind of unusual in our organization. So it was kind of an instant love connection. And what I have found is I just love Cassidy's style of caregiving. It's just, but with good boundaries. And that's, part of what I'm always so aware of. So I really appreciate that. And Cassidy is much loved by all of our people that work with her. And I know that you won a award recently. What's the name of which one you got?
The Art of Caregiving Award.
That's right. That's a wonderful award that anyone in our group can get, instead of just the nurses, who also get this fantastic big woo to do. But then people like the social workers who work for hospice and Cassidy, the CNAs, also can win this wonderful award. And we're nominated by people, and Cassidy won that. So you're in good hands if you work with Miss Cassidy. So I just thought I'd put that out there. Anyway, that's in a nutshell what I do. That was a quick synopsis of many years, many decades of being a social worker.
That's incredible. Wow. So you've had a really diverse portfolio, a really diverse
Yeah.
career then.
Yeah, it's a great degree to get. And I just, I always recommend to people if they say like, well, I want to work with people and I know that I'm really good with communication, and I always point them in the direction of social work, because back in the day, social workers used to make no money at all, but that's really changed a lot, especially depending on what part of the field you go into. And, certainly medical, social work, anything in health tends to pay a little bit higher than it would if you're working like for nonprofits, like a community agency and such. So it's a great field, and I'm happy to answer questions about it or just to talk about certain issues. I know there's probably a lot of people that have preconceived notions about social workers, and I completely get that, and I'm happy to answer questions or talk about that as well.
Well, that is something that you and I have talked about as well, just in our own conversations about the stigma surrounding social workers. And what I think is really awesome is that prior to working in hospice, the hospice platform in healthcare is a little bit different compared to, I would say, like your everyday average, skilled nursing facility or hospital. Whereas, in hospice, we CNAs, nurses, social workers, we're all sitting down and we are very much a team. When we are assigned a case, we are a team. And so working in outpatient hospice and working in that interdisciplinary platform has really put the forefront of what social workers do in front of me.
Yeah.
But I don't even know how to express my gratitude for social workers out as a clinician out in the field, because sometimes there are some things that we walk into that are like, I need help here.
Yeah, for sure.
It's so nice to be able to say, okay, this is a scenario where I need to call my social worker, and to be able to have them available and where we can address issues together and figure out the best outcomes for our patients. Whereas other healthcare settings aren't that way. Very rarely on the floor did I ever come into contact with a social worker beyond a, hey, how are you today?
Gotcha. Yeah, definitely.
So I think there is a stigma about social workers, about what their roles are. And I know that some of us out in the group and in other groups have had negative experiences with social workers. And so I would love to know your perception on that, and what that has been like for you. Is that a problem? Have you faced that before?
Oh gosh, yes, absolutely. Probably a little bit less so now, but certainly like in different areas that I've worked in, absolutely. And, absolutely, as far as being a school social worker, that was very challenging sometimes because, I think what people think about, especially people who are a little more like old school, don't really realize that social workers don't just work for social services, or they might kind of know, but not really know. And they just assume that a social worker is someone back in the day, especially if these are older people. Social work is an old profession, and they used to just, I think, be associated with the people that swoop in and take your kids away from you and place them in foster care. And that was, for my grandparents, that was certainly true. Like somebody from social services would come and swoop, so why would you trust someone with a title like that if you've had a life experience? And many of people who are, I'm quite a bit older than you, but many people my age or your parents' age certainly would be nervous about somebody knocking on their door because they see it as an investigator who's looking to get you in trouble. And I thank God I can say that things have largely changed where, social workers, for me, I like to think of it like, if we've received good training and we work for an agency that has a good outlook, what we're trying to do is to be a good advocate for people. Sometimes for people who, can't really advocate for themselves, children and seniors for sure, disabled people. So I myself like to think of myself as sort of, I know this is going to sound strange, but almost like a systems analyst. And there's a whole school of training in social work that's called like systems theory. And that's where we're looking not just at the person, but at their whole circle, their family, their loved ones, their family, their friends, their community, their workplace, their city, and it just, concentrically expands. And so we can go as tight in or as far out as we need to, hopefully like address what the factors are that are affecting the person. So
you're just taking that. Well, and I kind of, the way you had said that, I kind of link that to how I feel like, and I keep saying hospice, mainly because I just love the platform.
Healthcare.
But healthcare. But whereas like we embrace the person as a whole, you're really embracing that person and their background and their everything.
Absolutely.
That's awesome.
Absolutely.
Really like that.
Yeah, it's a really good degree to have. And I was mentioning this to you a little bit before we started live is, I think it's what I like to tell people who, I always have people say, oh, you're a social worker. That's awesome. I think sometimes I wish I was one because I like to help people. I was thinking of being a psychologist. And what I always tell people is, in my experience, although, I'm probably not as knowledgeable about the field changing of psychology, but I was taught I was going to be a psychologist, and I was luckily pointed in the right direction by a mentor in college saying, oh, please do not sign up, to go to get your master's degree in psychology. You can't really do too much with that. You can't accept third-party payments from insurance, so people can't go to you, and get reimbursed. They'd have to pay you out of pocket, etc. And psychologists tend to work more with the person and their brain. Mm-hmm. And social work as a field tends to work with the person and their whole system, usually their family, but then the system at large. And so it's kind of a great degree to have, and you can work in so many fields. Like you heard the things that I listed as possibilities. So in healthcare, you have this real intersection, right, of the person and then the healthcare systems coming in and out, and their families coming in and out, and financial, insurances. And so you're getting this real mix of people dealing with their fear, with disease, and how that's affecting families, and how to obtain, good health care and caregiving. So it's huge.
So I have a question, a loaded question. Out of everything you've done, Sharon, what has been the most rewarding? What has been the most rewarding? Like, where do you feel like hospice is kind of where you fit in, right? Like, is that kind of your thing, or what is your favorite?
Well, that's a really good question. Sometimes the thing I'm doing at the time is my favorite because I'm really into it when I'm doing it. And I know if I'm not that into it anymore, it's probably time to segue into something a little bit different. I would say philosophically, hospice is my favorite environment to be in. And I've often said, certainly until very, very recently that, I won't work in another. This is what I was, meant to do. But I also know from my life experience that sometimes you get called to things when you least expect them. So I would always stay open for sure. But about hospice is, this is sort of a weird thing to say, but I liken it to, I feel like there's two most sacred times in people's lives, like birth and death. So there's so many different ways you can, look at that. And with, when somebody's giving birth, like the parent is at their most fragile and open and in wonder and in fear. And so are they likely to feel similarly at a time of transition into the last part of their life. And so they're sort of similar. And lots of times, but not always, the person who's very sick at the end of their life becomes almost more like that innocent period of birth, where they're very dependent and beautiful things can happen in each, and they both feel like a miracle in their own way if you're lucky and you have a, you know, a positive experience. It's not always beautiful and peaceful when you're giving birth, and it's certainly not always that way at the end of somebody's life, but that's what we strive for, and it helps me if I kind of conceptualize it that way.
Right.
Yeah, yeah.
I definitely feel like hospice has been, I feel like everything that I've gone through as a CNA in the last 14 years has definitely prepared me for this job, you know, for actually entering into hospice. End of life care has always been hugely important to me. And I knew from the beginning, you know, from the first time I dealt with a patient passing into, you know, everything that we as certified nurses aides have to do for that patient and all of those things. I knew there was something to it. There was something more to it. And I actually have this story. So when I was 16, I got a job at a retirement home in the kitchen. And this retirement home, you had to be able to take care of yourself. But they came down for meals, breakfast, lunch, and dinner. And that is how I fell in love with the geriatric population. Like once I started serving these people their meals and, you know, saw the dentures in the water and saw all this stuff, I was like, oh my goodness, I love them. And there was this little Native American man, and he was missing an eye, and rain, snow, 50 below, didn't matter. This little man would walk all the way around this facility on the outside every single day, like morning and night.
Wow.
And I will never forget, he always ordered breakfast and coffee. Like that was breakfast. And you know, I would ask him if he wanted anything else, and never really said anything to me. And just other than thank you. Thank you. Always thank you when you brought it, you know. And it got to the point where I knew what he wanted. I brought it, and it was thank you. And that was the only interaction. So I grew up in a small town. So when I turned 18 and I went to my local nursing home and I wanted to be a CNA, I started seeing the people that I had served breakfast over the last 3 years trickle into the nursing home. And here comes this little Indian man, this little Native American man. And he was my patient, and I was really excited because, you know, here's somebody that I know. And so like once or twice a week, I gave him an evening shower. And as usual, he never said a word, really. And so I found some tea tree lotion, right? And I would rub it on his back, and the only noise he would ever make was, ooh, that feels good. And I know. And that just kind of was what it was. I didn't push it. I knew how this man was. It was, you know. And so finally one day he says to me, one eye, and he looks at me and he says, you know, I'm 100 years old. And I said, yes, sir, I do know that. And he said, I'm going to live to be 101. I said, awesome. Good for you. So a year goes by and we go on like this. And all of the sudden, here's his birthday, 101. So 3 months before 101, this little man, as people do, he kind of started to decline. He stopped eating, he stopped drinking, and we were going on that transition, right? He'd lived to be 101. They had a huge party. Like this was his thing. This is what he wanted. And I remember I had like 4 days off and I knew he was going, and I went in and I said my goodbyes. And I was fully expecting him not to be there when I got back, because it had been like 3 or 4 days. And it was the weirdest thing. I filled up my cart with linens and I stopped outside his door and I dropped off his linens and I sat with him for a minute and I just held his hand and I said, you know, you have lived to be 101 years old. And as I do with all of my patients, when I have the opportunity, I just told him how grateful I was to provide him care and to know him all of these years. And then I went about my business. And as I walked in the other room and I came out, 2 aides came out of his room and he was gone.
Unbelievable.
And so that was my first moment where I was like, okay, there is something to this. So I know that's a huge, long story, but I understand what you're saying. I know, right?
Yeah, totally. Wow.
I know. And that's why I love hospice.
Aww,
I'm so super excited about hospice. But on the other hand, we're talking about social work.
That's okay. Do you feel like I've, since you added me to the group a couple weeks ago, I've been peeking in on it, every couple days or so. And I just want to say, like, the kind of life situations that people have, it's just staggering to me. Like, the most of the world does not realize that so many of us, not me, so many unpaid caregivers are out there with their loved ones performing these absolutely heroic tasks on an hourly basis. And it's heartbreaking. And it's the hardest job in the world. I feel like parenting a little one and parenting an older one, it's the hardest job in the world. Like, you can't pay me enough to do that. You have to do that out of love.
Absolutely.
Right?
Absolutely. Well, yeah. I'm so glad you brought that up, because I really feel, first of all, it's an honor and a privilege for me to have created the Caregivers Hub, to see it grow into what it has been, and for it to be so big. And I love that we have medical professionals, trained professionals, and we have family caregivers together in one area where we can gain knowledge and experience. And, we have people like Sharon who can come out, and they have people like Sharon to go to and say, I'm having this situation. Can you point me in a direction?
Right.
And I feel like that is what I've noticed about social workers is, and if you don't know this about social workers, they're like you guys are like little hubs of resources and knowledge and awesomeness that until we realize that, now my brain is going, oh, social worker. You know what I mean? Okay, that would be good for social worker. Whereas before, my brain didn't kind of go there. It was like, okay, how do we fix this situation? Report it to your nurse, and then let her take care of it. Whereas now that I'm kind of realizing all the things that you guys do and the resources that you have, where I'm like, oh, okay, this is where I should reach out to my MSW about this stuff, and so if you're not utilizing a social worker, you should.
Yeah. So it's interesting. It's like, I feel like a lot of the people on your hub are pretty isolated themselves because they're home with their loved one caregiving. Does that seem accurate?
Absolutely. And I would say that for family caregivers, that is status quo.
It is, right?
For sure.
Yeah. So do you feel like with kind of, the advent of having things like Facebook groups and meetup groups and, other online support, do you feel like people feel like they're getting more support, or is it frustrating because it's only an online connection? And how does that?
So what I get a lot is what I have gotten a lot in the last, the hub was a fan page prior to being a Facebook group. And that started in March of 2016. So in just over a year and a half, we've reached 2,200 members all over the world.
Wow.
And most of them, their general consensus is, this is my only lifeline for support.
That's amazing.
I can't get out. My friends, something happens when people start going through terminal diagnoses and Alzheimer's and dementia. Friends and family sometimes don't really know how to help. They don't know what they can do. And then some of them really aren't prepared for the situation or to support somebody going through that road. Yeah. So they kind of end up falling by the wayside, and people furthermore feel isolated. So I definitely feel like the online presence and support systems that we have for people have opened up a line of support that they wouldn't have access to without it.
Yeah, absolutely. Thank goodness for that. I'm glad to hear that. Do you think that there's some things that I could be helpful with in terms of those people that are home with do you think there's any questions that they might have about anything, or should we just talk about social work?
I have a couple of questions. Absolutely. So this came from a group, because what I always do when I'm throwing these out there and when we are going to do these is my what's the word I'm looking for? It's almost like the caregiving groups that I throw out my content to, whether it's Lewy body dementia, whether it's home family caregivers, whether it's CNA groups, cancer groups, you know, I've kind of casted the net out there quite a bit. And so I'm always throwing out these questions to them. And I got a question that was both two questions about the same thing. So the first question was, do social workers determine if a person needs 24-hour care?
That's a pretty broad question. I guess it depends in what surroundings. Like, I'm trying to think in what context.
Well, I think like, okay, go ahead. Because so piggyback off that.
All right, and then I'll get to that. Yeah.
Okay, so go ahead and tell me what you think.
Okay, so I was thinking sometimes I think maybe people are afraid that if they're caregiving, but they're also still trying to work, or, you know, they're in charge of their family member somehow, that they're nervous that someone's going to come in, like the state or the social worker, or someone's going to make a report saying they're leaving this person at home, you know. So then maybe the question comes from that perspective, you know, who's going to determine that? Is a social worker from DSHS, you know, Department of Social and Health Services, going to come in, like welfare, and tell me that? I would say that that's probably the social worker who might be working for the state, might be part of the team that either, if they got a report about a vulnerable adult being left at home for safety reasons, would be one of the people who would come to assess the situation and to help decide, you know, is it safe to leave this person, or do they always need someone with them? So
Right.
Yes, I would say that would be part of the team. Do you think that is the type? Do you think that's what they were asking?
So I definitely, it's both of those things. Like for me, the minute I read that was like, oh, okay, like automatically my brain went to, you know, nursing. Okay. And how we, like in our situation, if that was the case, you know, we, you know, our nurses and our aides and our social worker would work together to make sure that from all standpoints that we had a safe caregiving situation. And then we would probably determine, and you and the nurse would confer, okay, yes, we need to bring somebody, you know, this caregiver no longer can do this by themselves, and we need to bring somebody in. So here's my brain went. Go ahead.
So sorry, my screen's freezing up a little. I apologize. So that's an interesting question, because the question itself sort of makes the question broader. So just because somebody needs 24-hour care doesn't mean they're going to have it. And that's a scary place to be as a caregiver, as a medical professional and part of a team. So yes, we have plenty of people who should not be alone for, you know, any amount of time, and are.
Right.
What you just said, you know, or do they need to have someone brought in? Yes, they definitely do need someone, but here's the issue. It's always financially motivated. It's always financially determined.
Right.
For people that have money and savings, or God, if they were like enough to be in a situation where they could get long-term care insurance, God bless them, because not enough people realized they needed it or could afford to get it. Because if you're on a budget, it's an expensive extra insurance to get. But boy, if there's any way people can afford that, get it now. I have it, right? Because we've seen what happens when someone doesn't have it. And if you're in a situation where you don't have money to pay for a private caregiver to come in, and if you're not low income enough to get, you know, Medicaid or Obamacare, as some people call it, you're really in a bad situation, because you're one of probably the majority, like the middle class, that can't afford to pay privately for caregiving, but you're not broke enough that you don't get it from the state. Scary situation.
That is a scary situation.
Every day I deal with this, every day. And I always feel so badly because I know how awful the caregiver is going to feel if they hear me say, or you say, you know, they really shouldn't be left alone. What can we figure out together to try to get you some help? So luckily for us, it's very little, but at least I can offer them a crumb, which is I can apply to have one of our hospice volunteers come to them up to 4 hours a week, which is nothing. But it might mean that that person at least could go shopping and not leave the person alone, or take a nap, or run an errand, or meet a friend to cry, or just or walk around the block or something. But that's only 4 hours. So, you know, private caregivers cost so much. And so, you know, sometimes I'll even suggest that we hold a family meeting. Often you'll have that one primary person who is saddled with 98% of the whole caregiving situation, and their families kind of closing their ears. They don't really always feel like they want to listen, because then they're going to have to do something. So it's tough because other people are working, right? We can't ask people to quit their jobs to come and help. But sometimes if we can have a family meeting, we might be able to make a schedule where we chunk a little bit of time. You know, yes, everyone likes their weekends, but you got to give a little bit in a situation like this. So if we were able to have even like 2 people chunk out a little extra time, that could be a lifesaver. And sometimes people, you know, can also be told that private caregivers, even though like where we are, I have to say that go in this general Seattle area where we are, it's expensive. And I don't know how much it is in other places. I'd like to think it's not as much, but you know, you have to pay good quality people. So it's often anywhere from the $23 to $31 an hour, depending on what someone's need is, and more for 24 hours, you know. So it's difficult, but I always like to say, you know, let's ask the agencies what the minimum amount that they'll accept is. Mm-hmm. I found that the minimum that I have found, it's changed. It used to be 2 hours. Well, they've upped it to like 3 to 4 hours minimum. Yeah. I have a great agency that I've been working with because they're so responsive, but they require 8 hours a week, which doesn't sound like that much, but it's a lot for someone to pay, you know, $27 times, you know, 8 hours a week.
Absolutely. And then
it's a lot of money.
That, oh my land.
Every week. So yeah. So we you know, we try to like make it so that that one person isn't in charge themselves. And if there isn't anyone else to help, we encourage them to go on, you know, their state's DSHS website and search for what they might be eligible for on the application. All the states have simplified their online applications for help, be it for COPES, you know, in-home caregiving that gets paid for, or for Medicaid, or for food stamps. They've really simplified the program. And so you can basically apply for all sorts of aid with one application now.
And where would somebody online go in any state to be able to find those applications?
Well, as the social worker, you know, for our people, I always have all these like links ready that I'll send to someone. What I would tell people to do is Google is your friend. I mean, if I had one of your caregivers, you know, that just was instant questioning us, I would tell them to just do a Google search and just say, like Medicaid in Idaho, you know, how to get Medicaid in Idaho. And you know, you'll look at the different listings and you want to find the one that says like, you know, like DSHS or State Department of. Other times you might end up in some other person's website that's just, you know, kind of an affiliate. You want to always look for the state website.
Okay. So
yeah.
The website. And then had it and I lost it.
Oh, that's okay.
Had it and I lost it. So kind of piggybacking on, like I said, both of these questions were kind of the same. But I thought this was really good because for those of us who are dealing, like if you're dealing with somebody in, you know, if you're in a hospital, you're in a facility, or you're dealing with hospice or something like that, social workers are usually like at the ready for you, at least they're available to you. Whereas
Absolutely.
if you're just home and your loved one is not on services of any kind, how would somebody reach out and find a clinical social worker?
So I think that most states have a senior services type of organization. Actually, most cities, to be honest with you, not most states. In the Seattle area, we have, you know, we have all sorts of senior things. Senior services is the one that a lot of people use, and they just do a Google search, and really, you know, all you need is access on your smartphone, and, you know, you basically can type down support for unpaid caregivers, and you're going to see things start to come up. I mean, I think people who are home probably have already tried that, or if not, you know, for sure, go for it. And you'll see that there'll be, you know, support groups and online support groups. And there's lots of places that have like caregiver support programs. Unfortunately, budget cuts we had a family caregiver support program attached to our hospice, but there was budget cuts, and maybe 6 months ago, unfortunately, they cut that program. It was family support.
Wow.
I know it's a big gap that they left. So sometimes hospitals have like a resource team. Ours does. Hospitals are a great place to call. You could even call like the social service department in the hospital and ask them, hey, I'm looking for, you know, people that might be able to push into my house. And usually they'll have like a limited amount of sessions. I think ours used to be 8 sessions, but that's a lot because you can spread them out. It doesn't have to be 8 weeks in a row. You could like make that last as long as you want. And then you talk to that person in your home. And even if you're just venting, thank God it's somebody that understands. Or you could hook up with someone who could then help you find the right resources. So that's a really good idea as well.
Have you ever heard of, and I think it's called, is it psychologist.com or psychology.com? But basically it's a list of not just psychologists, but it is like social workers. I mean, it's everybody from massage therapists to physical therapists. I want to say it's psychology.
It's psychology. Yeah, it's psychology.com, I think. Yes, that's not a bad place to find a specialist. For me, I always feel like it's a little bit of a marketing tool. So you just have to go into it being a savvy person, because it's very easy. People buy a spot on there, and, you know, they might be fantastic and it's their way of getting themselves out there. But it's very easy for me, if I wanted to say specialty areas and nobody's checking. They can just put what. So, I mean, it might sound good to be like family dynamics. Well, you know, is that really their specialty? Somebody might say geriatric populations, and I would hope that if they said that, you know, that was truly one of their specialties. But the, you know, the onus is unfortunately on us as consumers. You know, sure, you know, psychology.com or whatever, cross-reference that person, because lots of times either on Google or just a web search might have other reviews, you know, like different health reviews. Check Yelp also for private practitioners. People rate their experience.
So what would be some things that people, when they're doing their due diligence, would be looking for to find a good social worker? Somebody who's not just claiming that they're doing something that they're not, or they're specialized in it and they're not.
Well, everyone should know that whenever you eventually do find a person, whether it's like you're able to get someone to cover you and you can go get counseling or counseling support out of the home, you certainly could always look on. Each state has a licensing board, which I'm sure you've talked about before. And in that, you can look up a list of professions. It can be psychologists, psychiatrists, social workers, doctors, and nurses. They're all medical professionals who are licensed in that state, will be registered. You have to be.
Right.
And it will tell you sometimes it'll tell you how long they've had their license, which can be misleading, because if you get it from, like when I moved from New York, it looks as if I've only been a social worker for like 8 years. In reality, I've been one for decades. But in the state of Washington, for some reason, it only shows that. But it also will show if there are violations, or if you've had reprimands, I forgot the exact word, on your license, or complaints about you. And I've actually looked up people myself that I had some questions about, and I did see that there were some reports, and then it's public access. You can actually read the report.
Well,
so that's a really good tool. I don't know that everyone wants to go that deep down.
Well, but I think,
but you can.
I think just even talking about it, because here's one thing that I've noticed too, is I get this question quite a bit, like, Cassidy, how do I determine what is a good skilled nursing facility and what isn't? You know, or I brought my loved one to this place and it was beautiful, it was clean, but the care sucked.
Absolutely.
And for me, I'm like, my brain's automatically going to, okay, well, you know, there's a state survey that is available to you. And to check that out. And that's kind of the same thing that you were talking about with checking out the licensing, and whereas that's how you can determine if, and here's the kicker about that, is if you understand the jargon, you know, what F tag is, what a D tag is, and what a B is, and what those mean for a survey, and what those mean for a facility, and what that means for the quality of care that you're going to provide. So it's kind of, in my brain, that kind of is exactly what kind of the same to me. Whereas, you know, you can go and you can look up people's licenses. Well, that's kind of the same with these nursing homes. Their state surveyors are really going to show you, at least I think so, the accurate.
Yeah. And, you know, also, like in our state, and I'm sure it's the same in every state, we have something called, it's through DSHS, Department of Social Health Services. I'm quite sure that every state has this. It's what I just sort of informally call it, like the finder list. And so you'll type in what kind of facility you're looking for, whether it's assisted living, adult family home, skilled nursing facility, etc. And you can do an advanced search, which is what I always tell people to check the advanced box. And then you can specify, do you want something for dementia, for developmental disabilities, for mental illness, like all that stuff. And do they accept Medicaid? And then it's going to throw you out ones in a certain geographic area that you're looking for. Next to the name, because it's in a chart in a grid, on one of those columns will say whether or not they have violations. One good thing to know is that just because you have a violation doesn't make it a bad place. You know, the day the inspector came, maybe something was out of place that shouldn't have been. It doesn't make it a bad place. Then I'd want to ask, what were those like, let me see what that is. You know, you can even ask the facility and they have to tell you. So I guess back to the, oh, sorry, go ahead.
I was going to say, that's what I think. I think that just making those, I mean, I don't think that a lot of people are aware that they have the access to that, you know, that is a step that they can take.
It's out there and it's public, and you know, the law says that these are public documents. Huge variation in how beautiful something can look and what kind of care you get. I mean, we know, those of us in healthcare who push into facilities as well as people's homes, people are always apologizing to me, by the way, oh, please excuse my house. And it's like, I just laugh and I'll look at the nurse I'm sometimes with, because we go everywhere from, you know, mobile homes with practically no running water to mansions.
It's true.
So they're opening their door to you, and you know, they're feeling so vulnerable because here's a social worker coming in, and they're afraid of, you know, as I would be, of judgment and you know, possibly action if somebody saw something they didn't like. But that's not why we're there. But of course, as the person who's opening their home to us, they don't know that, right? So it's scary. But anyway, the quality of care is always going to be different than how it looks. You could be living in a mobile home that's not fancy and really small, and you could be providing like loving, stellar, amazing care to your loved one. And they could be in a facility that looks amazing, as you're like living rather independently. But if you are really sick and needing help all the time, you might not be getting the care that the families have been told you'll be getting. So it's all different, and you have to be a nosy body and get yourself in there a lot and watch.
Exactly. And that's one thing that I kind of want to impress upon everybody. You know, I feel like sometimes I run into this thing where sometimes maybe somebody is unsatisfied with the care that they've been provided, whether it's one of our people or somebody else that they've hired, and they feel like they don't have maybe the word's not the ability, but maybe they're struggling. They don't want to get somebody in trouble, so they're just accepting subpar care. And like my main thing is, you know, I would hope that people are providing good care. Like I always say, I want the hope to be that that's why you're here, and that's why we're in this industry, is you're here to provide good, compassionate, dignified, respectful care. But you don't have to accept subpar care as just the standard. You know, I've always kind of said, you know, if you're unhappy with your care, you can reach out to your nurse or your social worker. You know what I mean? Like I don't know, just don't accept subpar care. Like just know that you do have a voice as a caregiver.
Yes, absolutely. You know what, I also, to piggyback on that, I've worked with a lot of nurses between home health and hospice. I've had many different nurses come in and out, as you know, as all places do. And I've really seen the gamut between, you know, nurses who are very directive and tell people what they think, and they just kind of stomp on the patient and the family's goals of care and family style, and they tell you what they think that you should do. And I've had nurses that also come in and they say, we are here to meet your goals of care, what's important to you today, etc. So I mean, there's a wide range. And what I've always said when I go by myself, or whether I'm with a nurse when I'm first starting with someone, is you're going to find there's many different people coming, you know, sometimes many different people coming in and out of your home. And if I or one of the nurses or assistants is coming in and you find that they're kind of trying to lead you down a path that you're not really comfortable with, or asking you to, you know, take care in a certain way that you don't feel as comfortable with, I'm going to ask you to tell me, you know what, you might be like that, you're coming on a little strong, you know, because as a professional pushing in, if I'm not being sensitive to what the family goals are and what the family system is like, I don't want to come in and try to change that. I'm here to complement what you're doing, and I'm not coming in somewhere looking for trouble and looking for trouble spots. I'm there asking, how can I be helpful? And if I happen to see something that I think could be improved, what I usually would say is it okay with you if I give you a little bit of feedback on whatever it is? Almost always people will say, yes, you know, please give me feedback. They don't have to agree with it, but then I've asked them before I start stampeding on them with what my thoughts are. Because yeah, you're just asking permission politely. And they could still disagree, but, you know, basically, I always want to respect that. And hopefully, as a caregiver, you know, in the home, people are going to appreciate that and then feel listened to and not stampeded over.
Exactly. Well,
So,
I think that's a great thing to talk about and to address in the healthcare industry in general, because oftentimes I think maybe sometimes as medical professionals, we forget that, you know, we're so in tune to what we've been taught and how, you know, and also not just what we've been taught, but, you know, the policies and the procedures and the mandates and things like that. So it's kind of like we're always, as professional caregivers and medical professionals, we're always walking this line where, you know, we want to honor that person and their family dynamics, and that this is their transition. And, you know, I always like to say it's my responsibility to take care of my patients how they want to be cared for, how their families want them cared for, and how their facilities want them cared for.
Exactly. And, you know, obviously you and I are seeing unsafe situations sometimes. I mean, not frequently, but sometimes. And so, you know, we'll suggest to whoever's the primary caregiver that, you know, maybe this person shouldn't be left home alone, or, this is a real fall risk, how things are set up in your house, and, can we make some suggestions to you, or, things like that. That could feel intrusive. I mean, here's this person coming in labeled as, professional. You're the one who's sitting there dealing with it 24/7 or close to that. So it's really also on the caregiver to say, I appreciate what you're telling me, some changes or not. But push comes to shove, you can't make anybody do anything. You can only suggest and hope. And that's where it gets a little tricky as a social worker, because many of us in healthcare, almost all of us, are mandated reporters. I know you are, and your colleagues are. So are, agency caregivers who are paid through the agencies, and in hospitals, people who do direct care are as well. So that's where it gets a little funky. I certainly never want to be calling like adult protective services on people. I really don't. And I'll try anything.
Either, but there are, okay, so I'm so excited that we brought this up, because I feel like as we discussed a stigma around social workers, I feel like for healthcare professionals, there's also sometimes a stigma about reporting. That when you report something or somebody, that you are a bad person, B, that you're trying to ruin whatever, and here I had this scenario, and I actually, for the first time in 14 years, had to make an RCS report that I was.
Why don't you say what that is as different to APS?
So APS is Adult Protective Services, and RCS is Residential Care Services, right?
I think so, yeah.
So residential care services are the people who are going to be coming into adult family homes, and I believe private homes, correct? Oh, no, APS is private homes.
It's all facilities.
Okay.
It would be a facility. So if you suspected that somebody had been either abused or was not being, safely taken care of in a facility, you are mandated to call RCS. If somebody's in the community at home or saw something, you would call APS. And if you felt like something was kind of immediate, you would call the police first rather than APS, right, because that's like an immediate danger thing. But yes, you got that. Okay, so you needed to call RCS.
So I mean, and it was just a series of things that had happened in an adult family home in like the span of a half an hour that kind of led me to go, oops, no. Yeah, and first of all, I wasn't happy with the condition my patient was in when I found her. And I just wasn't really happy with the conditions all around in the facility. I mean, they were kind of tucked back into this back area where there wasn't a whole lot of people. And these are bedbound patients. You know what I'm saying? So it's kind of this weird feeling. And thank goodness, like I said, that in our organization, we work as a team and we are there to support each other. And so reaching out to MSWs and, the AOC on call and everything was it was a process. But here's what I've decided. I don't think that we should be reporting every little willy-nilly thing, right? Right. But not reporting the things that matter because we feel like we don't want to get involved or we don't want to get people in trouble. Here's the deal. If we don't do those things, then sometimes shit never changes. It just continues to be this perpetual cycle of subpar care that becomes, potentially abusive, potentially neglectful. I mean, it's always borderline somewhere. So I feel like we need to report those things if we see them, because that's how change happens sometimes. Yeah,
and I think that also, it's decision because we know that we could be fired. And I don't mean fired like we won't have a job. I mean, like we have a relationship with the patient and probably their family. And even though, we may have asked them several times to please try to address this, let's try to address it together. And if the same unsafe situation has not been like resolved at all, even progress towards that, then we have to call and make a report. great relationship with our patient, we might be asked not to come back to the home, you know, or the situation with and that's just heartbreaking.
Yeah.
Because then we A, feel like nobody's eye is going to be on them and they're not getting even the basic, and B, doing the good work that we're doing, and we have a relationship and we care about those people. So it's a dilemma for us as well, each and every time. And I've been making reports every now and then since I've been, you know, in my early 20s, you know, and this is decades later, and I'm perfectly comfortable making the reports, but I don't ever like it. It's not what I want to be doing. Sometimes, though, I have to say, wonderful things have happened when I call, like a resistant elderly couple who has absolutely refused any kind of help. We finally just say, okay, we just have to call, even though they're going to be mad at us. And somebody comes in from, you know, adult protective, and they are able, with their connections and programs, that they can make things happen fast. They can access them to caregivers quickly. They can give them options of things that I don't have any access to. They can get people to help solve issues that I can only wish for. So, and then I've actually had family say to me, I was really pissed at you. I was like, I hated you guys. I can't believe it. I was embarrassed. I was pissed. But because now I have these services for my parents or for my wife or whatever that I didn't have before. So, and that's for even, you know, people that we've had to call on when I worked in a school. They didn't have help, and then they got help, and they got put into programs, and maybe they got access to Medicaid or, you know, financial help. Anyway, so I do want to be respectful of your time. I know it's 5:57.
It's okay. Don't worry. I just have one little nugget that I wanted to talk to you about.
Please.
And this is kind of a hospice Medicare question.
All right.
So one thing that we run into out there is hospice eligibility with Alzheimer's and dementia patients.
Yeah.
And I was kind of explaining this before we even got started that, you know, we as a hospice, we have strict Medicare standards and mandates that we have to follow via eligibility. And it is so much impressed upon us because we as hospice services are funded by Medicare, right? Medicare, yeah. And so oftentimes I get this, you know, the thing that's happened is we have a lot of people who end stage Alzheimer's and dementia are extremely mobile, yet they're physically, their body is dying. And based on the system and Medicare standards and eligibility rules and regulations, I don't even know if that's the right word.
Like requirements or something.
Right. So the question was thrown out to me, whose responsibility is it within the hospice team to make sure that their loved ones are eligible with Alzheimer's and dementia for hospice services?
So eligibility is a really tricky question. And, you know, it's also, there's a lot of variability because it's ultimately a doctor who is deciding whether or not a patient meets the criteria for any, you know, eligibility illness, whether it's end stage Alzheimer's. And dementia is such a catch-all phrase that I'll have people saying that to me. But in my mind, it's sort of like a piece of many other things. So it is really, it's not really subjective. There's certain criteria that the docs ask questions, and then the team who's admitting or hoping to admit a patient are looking to like kind of look at different criteria and see whether a patient meets that. If it's borderline, they're always going to be calling, you know, what we call the doc of the day. We always have someone on hospice each 24-hour period that is available to say, let me ask you some other questions. Does the person do A, B, and C? Okay, that's like 5 things out of 10. They might not quite be there yet. And if we allow them to go on under that diagnosis, Medicare won't cover it. And then they're just going to have to get booted out. I'd rather not let them come in and then say sorry. So there either a skilled hospice doctor is always going to be will frequently try to see, is there another eligible category that person could be under? There's something called muscle weakness, which we see a lot, and it's the most bizarre category. Like, what does that mean? Way it's a little fuzzy to me, and to everyone. It's sort of a way that when you're not quite clear about and someone's going in, but you know that they're just failing, they're just basically failing to,
to thrive, for sure.
Yeah, exactly. It's a way to kind of get someone in, and then generally Medicare won't pay for that too much anymore. So you'll quickly try to figure out and fine tune what category do they really fit in.
Right.
But Medicare's so strict. Like, we in hospice would love to let everyone in because that's what we do. We care for people who are at the end of their time.
Right. Let all the people in.
Let everyone in. But it's smart of the docs to be so stringent. And I think it is really hard. Generally, when someone is presenting with end-stage Alzheimer's, they're not out there moving that much. The end stage is really pretty end stage. But you probably know more than me from people you're hearing from.
I mean, and I've personally seen it. I mean, yeah. Whereas sometimes just physically, and here's another thing that I think that we need to take into account when we are considering hospice eligibility with end-stage Alzheimer's and dementia. Alzheimer's and dementia, just over the last 5 years, education and awareness has exploded.
Yeah, for sure.
Because of the fact that 1 in 6 people are caring for someone with Alzheimer's and dementia, has it themselves, or has lost somebody to it.
That's huge.
And that's an epidemic. It is the 6th leading cause of death in the country.
Crazy.
So our education and our standards are always changing with the more information that we have. And sometimes it feels like our mandates and our policies and procedures have not kind of caught up with that yet.
Mm-hmm. Okay.
And so, I mean, there has to be something said for hospice. What can we do for this person whose brain is literally shutting down, but not allowing their body to shut down?
Yeah, that's true. I would say that even if your loved one is not qualifying like today, that's not to say in a month that they won't qualify because they're going to present a different picture. So don't be, I know it's discouraging, but I would say don't let that prevent you from feeling like you just want to ask for another referral to have the hospice team and evaluate your loved one. Because things really do change. And we often have people who, on the day that the team came out and with the records they're looking at, they looked a little bit kind of too good to fit into that criteria. And maybe a week later, we might get a call that somebody is barely responsive. So should we have let them in? Of course. But on the day they presented, meet the Medicare criteria. Right. So, yeah, it's a really sticky one. And I would say, just don't give up. Just keep asking for referral if you really suspect that your loved one, could benefit from hospice.
Perfect. And just also another thing to remember is all hospices, although we operate under the same rules and regulations, we are not all the same.
No, in fact, I had a really great friend from college just instant message me this morning, and she lives in New York and her mother lives in Florida. And so luckily they have money, and that means that they are able to stay in New York and hire 24-hour caregiver for their mom to stay in her place, which most people cannot afford that. I couldn't. She's asking me about hospice. So I said, let me just look. So I did a Google search on, it has to be like a Medicare regulated hospice. It can't just be, there's hospices that are not Medicare.
Right.
And in order to have a good one with the right guidelines and criteria, they need to be Medicare approved.
Right.
And I looked, and what I found in Palm Beach County, where her mom lives, there's 90% are inpatient settings. Right. They didn't hardly have any community hospice, home hospice like we do. Right. We also have a care center where we are, but for us, it's just short-term inpatient for symptom management.
Right.
But in Florida, evidently they have lots of centers, which is why when people come to us, they're like, well, I'm on hospice. When am I going to the center? And we have to break the news to them. You're going to be doing it at home. And we have caregivers who get really mad at us because they didn't ask the right questions. And I think we assume that they knew. Right. So really different wherever you go, and you have to find out, do you guys push into us, or do you have a center that our loved one would, make as their home? So.
I love that you brought up that non-Medicare hospices. I didn't even realize that those even existed.
They're not accredited by Medicare, and it's not to say they're awful, but they don't have the same regulations. Yeah.
It seems like what?
Yeah, it's true.
Because I mean, when we say we operate by strict standards via Medicare, we do, because here's why, and here's why they're cracking down. Like, there's been multiple cases throughout the country, and I believe this one I read in Texas. They shut down a hospice to the tune of $60 million, where they had patients on hospice who were not eligible, kept them on hospice, and medicated them when they didn't need to be medicated. And some of those things were resulting in death. And so that is your hospice down, your nurses, your doctors, everything. And so that's why it's extremely important for Medicare to make sure that when we say we're a hospice, we are following their rules, because this is what can happen if we don't.
Yeah, it's a pain in the butt for us a lot, because there's so much paperwork and so much things we have to, the minutia, and it gets really annoying when you just want to provide, patient care. But I also appreciate the fact that without those, there'd be a lot of shortcuts taken, and it's patient safety has to come first. So we'll just deal with that. But anyway, I'd love to come back on your show sometime and talk about maybe specific questions that people have, just about, not so much even just about social workers, but maybe I could help if people just have general questions about health between the two of us. We could have just a little session, and we'll just answer questions about caregiving and health and all that.
Well, Sharon, I am so glad that you came out and that you are part of the Caregivers Hub, and
thank you.
I'm so grateful you're my friend.
Oh, thanks. Vice versa. Vice versa. If people have other questions, since I am a member of the Hub, could they just write my name and it would come to me through Facebook?
Yeah, it should. They should be able to tag you in any post if you are a member of the Hub.
Yeah, but if not, go through Cassidy.
What was that, honey?
If not, they can go through you, right?
Oh, absolutely. Absolutely. And, we will figure out a way to make sure that you guys connect, and that we have everything taken care of. So on that note, Hubbers, make sure that you tune into these Caregivers Hub Hangouts every single month. So it's October, November, but in December, I have something. So here's the beauty about growing the Hub and about networking and all that awesome stuff. I have come into contact with a nurse practitioner who has agreed to come out on December's Caregivers Hub Hangout and talk to you about dementia and Alzheimer's and all sorts of badass things that nurse practitioners take care of and what we address in. I've been watching her videos, and she has some great knowledge about Alzheimer's and dementia, about understanding and approach.
Awesome.
So you tune into those things. And on that note, have a marvelous Sunday. Have a great October, and all my love to you.
Thank you. Bye, everybody.